Aires. Y sin perder más tiempo, vamos a pasar al siguiente bloque, que es un bloque de una conferencia magistral por la ACOG, que es la American College of Obstetricia y Gynecología. En esta oportunidad vamos a tener a la doctora Kathleen Anthony, quien nos va a hablar ahora sobre obstetricia y COVID-19, un tema de absoluta relevancia y vigencia en estos días. La doctora Kathleen Anthony es un médico especialista en medicina materno-fetal de la Universidad de Wisconsin, en Estados Unidos. Es una especial colaboradora e investigadora en la cuestión del problema del virus del Zika durante el embarazo y actualmente es integrante del Comité de Inmunizaciones de la Universidad de Wisconsin, en Estados Unidos. Con ustedes dejo a la doctora Anthony. Muchísimas gracias.
Hello. Thank you so much for inviting me to come speak today about COVID-19 and pregnancy. My name is Kathleen Antony, and it's a real privilege to be presenting at the Peruvian Society of Obstetrics and Gynecology here in August of 2021. I have no relevant financial disclosures. I'll jump right into my talk because I know we have limited time. The learning objectives for my talk today are I'd like to discuss expanding ideas for options regarding prenatal care in the time of COVID, review current epidemiologic trends for COVID-19 and pregnancy, discuss the physiologic changes of pregnancy and their effects on the care of critically ill mothers, review treatment considerations for COVID-19 and pregnancy, highlight changes to labor and delivery, the labor and delivery units during the pandemic, and also to learn about the guidance regarding the COVID vaccine in pregnancy. So just regarding prenatal care in the time of COVID, going through some guidance from the Society for Maternal and Fetal Medicine, they indicate that necessary and indicated medical care should not be avoided due to COVID-19 or COVID-19 positive status of the patient. They say outpatient practice accommodations should be developed to ensure continued medical care, but they do recommend trying to consolidate visits geographically and within clinics as much as possible, meaning if someone normally goes to one clinic for their prenatal care and a fundal height check, but somewhere else for ultrasounds and that kind of thing, they recommend trying to kind of consolidate that. And so if someone needs an ultrasound, perhaps also checking their blood pressure and going through their prenatal symptoms and making sure things are going smoothly at the same place and time geographically, so that they don't have to visit multiple sites. They also recommend that antenatal testing should still be performed for the usual indications, but to consider consolidating in a similar manner. Telehealth may be considered if feasible and accessible to patients and clinics. This can be variably accessible depending on where someone lives, depending on whether they have reliable Wi-Fi access or good cell phone coverage. And we know that that can vary widely based on where someone lives and things like that. I read that in Peru, COVID-19 has reversed about 5 years of progress in reducing maternal mortality, where the maternal mortality ratio per 100,000 live births increased from 62 in 2019 up to 92 in 2020. But interestingly, COVID was not the main cause of death. Only a fraction of those were caused by COVID-19 itself. And the thought was that these increased deaths were due to kind of later presentations of care or barriers to care, or perhaps patients waiting too long to seek care because perhaps they were worried about going to the hospital due to COVID-19 going on or things like that. And we observed some similar trends in the United States where patients had fears of going to the hospital because of COVID-19 and opted instead to have babies at home or to present much later for care than they otherwise would have. And this also increased, the severity of illnesses with which patients presented. Perhaps they had worse preeclampsia, by the time they presented they had HELLP syndrome or something rather than presenting just when they had elevated blood pressures. And so essentially the guidance is to not change prenatal care, to continue allowing patients access because we saw that reducing that access or patients not coming in as soon did result in increased morbidity and mortality. Regarding the likelihood of infection, pregnant people are not more likely than non-pregnant people to actually get infected with COVID-19. The overall rate of becoming infected is the same as in the general population, and the rate of asymptomatic carriers appears to be similar to the non-pregnant population. In the United States, as of late July, there were a total of 101,000 cases of COVID-19 among pregnant individuals and 114 deaths, and kind of the week-by-week number of cases is kind of shown here on the graph on the bottom, showing that there was kind of an early peak in March, April of last year, the main wave, of course, happening in June, July, and then the largest peak occurring kind of in November to January of 2020 to 2021, and then with some smaller waves. We do anticipate another larger wave due to the Delta variant increasing in prevalence in our country. Looking at Peru, I wasn't able to find the pregnancy-specific data, but the new daily cases in Peru shows kind of a similar trend with, the rise of the wave, and then, kind of a bigger peak sort of in February and March of this year. In the United States, pregnant women with COVID-19 who were hospitalized, there were 17,000 total hospitalized cases. And looking at exactly when pregnant women were getting infected with COVID-19, the majority was in the third trimester. Part of this may be because of some surveillance systems that we had in place where at the time of admission for labor and delivery, pregnant people had a COVID swab so that we could appropriately use PPE when going in and out of the rooms of pregnant people with COVID. And so this may be kind of part of the reason for the boost in the third trimester. So some common questions are, does COVID-19 infection cause problems for the babies? There's not a clear increased risk of miscarriage, and a study that just came out very recently also showed a clear increased risk of stillbirth, although that's a little controversial. Importantly, there's no clear increased risk for congenital anomalies. So COVID-19 is not like Zika, which classically causes congenital Zika syndrome with microcephaly and neurodevelopmental changes. Also not like rubella, which causes a syndrome very similar to Zika. Overall, low risk of babies acquiring COVID-19 from their mother. Vertical transmission through the placenta is low. The placenta doesn't have many receptors for the virus. Placenta amniotic and cord blood tests are very rarely positive. And early reports from Peru also suggest a very low risk of vertical transmission, looking at publications from kind of last spring. There was one published case report of vertical transmission with subsequent need for emergency cesarean delivery. In that case, there was no delayed cord clamping, no skin-to-skin contact, and this happened to be a case report from Peru. But overall, the larger case series did not really demonstrate significant vertical transmission. Looking at lab testing results for SARS-CoV among infants born to women with COVID-19, an overall low chance of positive PCR in those babies. So looking at kind of pregnancy complications, we do see that COVID-19 can increase some pregnancy complications, notably increased chance of preterm birth, which is potentially a little bit more controversial given a more recent publication. It increases the chance of preterm birth, both iatrogenic and spontaneous. Iatrogenic preterm births, of course, occurring if the mother is severely ill and decompensating, and there's a need to deliver the baby either because of a thought that would improve maternal status, or in the case of such cases as like a maternal code and things like that. There are also reports that it increases preeclampsia risk due to some of the vascular changes that COVID-19 can cause. There was a recent meta-analysis published in the American Journal of Obstetrics and Gynecology showing increased risks of preeclampsia, and it also proposes some potential biologic mechanisms for this. It also increases the likelihood of needing a cesarean. Looking at data from the CDC on COVID-19 and birth and infant outcomes, overall around 12.6% deliver preterm, which is slightly increased but not terribly different than the overall increased risk of preterm birth in the United States. Looking at kind of labor-related concerns for the OB provider, The CDC says that forceful exhalation during the second stage of labor, such as when the patient is breathing very heavily because they're pushing, is not considered to be an aerosol-generating procedure for respirator prioritization during shortages over procedures that are more likely to generate higher concentrations of infectious respiratory aerosols. However, the Society of Maternal Fetal Medicine and ACOG do give some guidance saying that it would be reasonable to wear an N95 mask when a provider is caring for a patient during an aerosol-generating procedure such as second stage of labor for someone who is pushing. Looking at breastfeeding, generally we do recommend still having a patient who has COVID-19 breastfeed their infant. The recommendation is that the mother wears a mask if they're within 6 feet of their child if infected, and to wash their hands for at least 20 seconds prior to the breastfeeding. And the Centers for Disease Control and Prevention has a nice infographic here talking about if you have COVID-19 and choose to breastfeed, wearing a mask while feeding the infant, or having someone else feed pumped milk to the infant, and kind of what the steps for that would look like. Now, COVID-19 in pregnancy does seem to result in higher severity than the non-pregnant people. Pregnant people infected with COVID-19 get sicker than non-pregnant people infected with COVID-19. Pregnant people are more likely than non-pregnant people to require ICU admission with a rate of 10.5 per thousand versus 3.9 per thousand, which is around 2.5 to 3 times more likely with an adjusted, with an ARR of 3. Pregnant people are also more likely to require invasive ventilation at a rate of 2.9 per thousand versus 1.1. So this is comparing people who are pregnant with COVID-19 to people who have COVID-19 who are not pregnant. Looking at kind of overall numbers in the United States, almost 450 cases of pregnant women with COVID-19 have been admitted to the ICU. About 100 have required invasive ventilation, and around 25 or so have required ECMO. Pregnant people infected with COVID-19 are also more likely to require ECMO, which is kind of that slide on that little bar on the far right part of that graph, at a rate of 0.7 per 1,000 versus 0.3 per 1,000. That does overall seem like a low risk, but it is a little more than twice as likely compared to non-pregnant people. Mortality is also much higher, at a rate of 1.5 per thousand versus 1.2 per thousand. Now, this graph compares pregnant women with COVID to pregnant women without COVID. So everyone on this graph is pregnant. That's different than the slides before where it was comparing people with COVID who are pregnant versus not pregnant. This is one where everyone is pregnant, but they either have COVID or don't. In this study, they studied pregnant women with COVID-19, who are shown in the orange, and those without COVID-19. And you see that those with COVID-19 had higher mortality, a much higher intensive care unit admission rate, a higher rate of preterm birth, slightly increased stillbirth and neonatal death, and also a higher rate of admission to the neonatal ICU. In the United States, we also see notable racial and ethnic disparities, with a higher than expected likelihood of being infected for people who are non-Hispanic Black or Hispanic or Latinx. There's also a higher risk of death for people who are non-Hispanic Black, and a higher risk of death for pregnant people in the United States who are Hispanic or Latinx. So next I'm going to discuss physiologic changes of pregnancy and their effects on the care of critically ill mothers. Here are kind of shown the physiologic changes of pregnancy summarized on this diagram. The most relevant ones I'll go through here. The gravid uterus pushes up on the diaphragm. Over the course of pregnancy, this results in a decrease in the functional residual capacity, a decrease in chest wall compliance, and a decrease in respiratory system compliance. Also, there's a lowered oxygen reserve due to this decreased functional residual capacity. And there's a rightward shift to the oxyhemoglobin dissociation curve because the maternal blood needs to offload some of that oxygen to the fetal hemoglobin. There can also be some difficulty laying supine late in pregnancy based on both kind of cardiovascular changes and needing compression of the inferior vena cava and can also be harder to breathe. Also of relevance are narrowing of the upper airways and increase in snoring. So some physiologic changes to think about are increased heart rate. There's also increased risk of thromboembolic disease, which can be a problem with COVID-19, and altered cell-mediated immunity, making pregnant people more susceptible to certain types of viruses, such as COVID-19, and also, influenza and other things. Looking at the airway obstruction during pregnancy, there's increased edema due to estrogen. There can be increased nasal congestion also due to estrogen. And airway obstruction increases also in labor and in the setting of preeclampsia due to kind of fluid shifts and things like that. And if someone also has obesity, the airway patency is worsened even by that. Looking at kind of the Malampati class, with class 1 being, you can see the uvula, the pillars of the tonsils, the tongue. Classically during labor, someone can go from a class 1 airway all the way to a class 3 airway, kind of shown here in panels A and B. As I mentioned before, the physiologic changes of pregnancy also change kind of the lung volumes with a significant decrease in the functional residual capacity due to the elevation of the diaphragm. The functional residual capacity decreases by around 20%. As a result of this, pregnant patients desaturate their blood faster than non-pregnant individuals due to these differences in functional residual capacity. Here you can see that pregnant people, on here is a graph that shows kind of oxygen saturation on the y-axis and the time of apnea or not breathing on the x-axis. And you can see pregnant individuals desaturate much faster than non-pregnant individuals, kind of shown here. On the left, it also shows kind of how long it takes to desaturate for a normal adult. And you can also see here kind of the effects of obesity. And so if someone is pregnant and obese, they will desaturate much, much faster. For example, in someone who's not pregnant, it will take them around 7 to 8 minutes to really desaturate, if you need to intubate them, as compared to someone who's pregnant taking around 3-ish minutes, or if they're pregnant and obese, 1.5 to 2. So I'll review briefly some treatment considerations for COVID-19 during pregnancy. And it can also depend a little bit on the disease classification. Patients who are asymptomatic have essentially no symptoms. These people with asymptomatic disease are usually caught based on surveillance and screening that is done. For example, on labor and delivery, if someone comes in to deliver, we do a swab. They have no symptoms, they test positive, they would be considered to be asymptomatic. Mild disease, things like flu-like symptoms, and classically they don't have dyspnea, shortness of breath, or abnormal chest imaging. Moderate disease is when they start to have evidence of lower respiratory tract disease, but they're able to maintain an oxygen saturation over 93% on room air. Now, this is the classic definition. During pregnancy, we do recommend oxygen saturation be maintained above 95%. And we also usually will screen these folks with kind of an exertion test to see if they can walk up and down the hallways or to the bathroom and back. And we would consider admission if they desaturate to less than 95% on exertion, because we want them to maintain that oxygen saturation over 95% at all times. And so if they're desaturating with ambulation, we consider admitting them as well. Severe disease is when they have tachypnea, a respiratory rate over 30, hypoxia, oxygen saturation less than 93% in the general population, or 95% if they're pregnant. A PaO2 to FiO2 ratio less than 300 if we happen to have that information, or over 50% of lung involvement on imaging. And critical diseases when they have multi-organ failure, dysfunction, shock, respiratory failure requiring mechanical ventilation, or high-flow nasal cannula. Kind of looking at the time course of the disease, early on there's a viral response phase, which kind of turns into a pulmonary phase, and then stage 3 later on, it's kind of all about the host inflammatory response. Lab abnormalities that we classically see are lymphopenia, thrombocytopenia, elevated liver enzymes, elevated LDH, elevated CRP, elevated D-dimer, and acute kidney injury. If signs we tell patients to watch for at home are worsening shortness of breath, tachypnea, a fever that persists despite Tylenol or acetaminophen, inability to tolerate oral intake, low oxygen saturation if they happen to know that, if they have persistent pain, confusion, lethargy, or are turning blue. I'm next going to discuss briefly ARDS, and here's a little cartoon that kind of illustrates how this happens nicely. Essentially, there's edema in the lungs, and so the blood is less oxygenated. The heart tries to pump into the organs, but obviously they're not able to get adequate oxygen. On chest x-ray on the left, you can see kind of a healthy lung, and on the right-hand side, you can see the lung of someone with ARDS. There's this is kind of the severity of ARDS. I won't go through this in detail, but essentially it will depend on kind of how their oxygen saturations are doing. In terms of management, when considering inpatient versus outpatient management, if someone is completely asymptomatic or only has very mild symptoms, we typically recommend outpatient monitoring with a 14-day self-quarantine. We tell these patients to wear masks at all times and to remain isolated if they're outpatient or inpatient. If they are doing outpatient monitoring, we recommend they self-assess their symptoms. Ideally, we don't want them to be alone at home, so that if they do get worse, someone can bring them in. If they have a pulse ox at home, and we understand most people don't have that, but a few people do, we tell them to use it, and we tell them parameters, to come in if their oxygen is less than 95. We also consider telehealth visits, if possible, for regular check-ins, where we can schedule these. We can do these in a format similar to how I'm giving this talk today, via a camera and kind of a microphone, set up where we can in real time use something similar to Skype or Zoom, or there's a myriad of other apps where we can talk to the patients, or also just setting up a phone call if that's simpler. There's also consideration for an outpatient follow-up at least once within 2 weeks, via either, as we mentioned, in person or via telehealth. The advantage of telehealth being that obviously there's a lot less risk of getting other folks in the clinic sick. We also discuss reasons to call a healthcare provider, which are similar to what we said on the other sheet, on the other slide, which is essentially worsening shortness of breath, breathing fast, fever over 39 degrees, inability to tolerate oral hydration, low oxygen saturation, chest pain, new confusion or lethargy. We tell patients to watch for blueness in their fingertips, lips, or face, or any OB complaints such as contractions, vaginal bleeding, or decreased fetal movement. If they think that they're going into labor or anything is getting worse, we usually just tell them to come on in. Inpatient monitoring might be needed if their oxygen is low. We also strongly consider this if they have comorbid conditions, like if they have underlying diabetes or high blood pressure. A fair number of our patients have underlying kidney disease. Some may have underlying cardiopulmonary disease. They might have been born with a congenital heart defect that has been repaired or not. Any of these patients, if they got COVID, we would consider admitting them. Or if they're immunosuppressed due to, say, having had an organ transplant, or if they're on immune-modifying medications for rheumatologic disease or things like that. We also recommend admission if their fever is persistent despite treatment, or if there's concern for secondary hemophagocytic lymphohistiocytosis or cytokine storm syndrome. I'll show the criteria for this on the next slide. When I'm thinking about this, I actually bring out this table every time, just because these numbers aren't terribly regular and you also have to add them up. Scores over 169 are considered to be high risk for SHLH. It's not specifically validated in pregnancy, but we do use it a fair amount. Although sometimes we'll use kind of a lower threshold for admission than in the general population. Essentially here we're looking for temperature, whether there's any organomegaly, whether there's cytopenias, for example, thrombocytopenia or neutropenia, triglycerides, looking at what their fibrinogen is, and that sort of thing. If we're doing inpatient monitoring, if they're mild to moderate, we'll usually do vital signs every 4 to 8 hours. If they're more severe, every 2 to 4. If they're critically ill, we do continuous pulse ox and telemetry and record things every 1 to 2 hours. We also typically do fetal monitoring, for anyone for whom a delivery would potentially be indicated. And so at my hospital, we typically would consider delivery for anyone who's over 24 weeks pregnant if there's signs of fetal distress. And so we'll do continuous fetal monitoring for anyone who's requiring supplemental oxygen, with the idea being that if there is evidence of fetal distress, we can use that to either try to optimize mom's medical condition or in certain situations consider delivery, if the mom is sufficiently stable to tolerate delivery at that time. At the University of Wisconsin, which is where I practice, we do have some guidelines on medical treatments as well. And I'd be happy to share my slides and also to share these recommendations, but essentially the treatment recommendations are depending on how severe the disease is. For example, if someone is requiring new or increased supplemental oxygen, typically we treat with dexamethasone, remdesivir, both, and in certain cases we would consider monoclonal antibodies as well. And so there's kind of a table where it says, depending on how bad their disease is or whether they need high flow device or mechanical ventilation, that will kind of target what therapies we're going to give. For example, we give dexamethasone and remdesivir for all on or new increased oxygen requirements, and tocilizumab for some. The dosing we use is 6 milligrams of dexamethasone IV or PO for up to 10 days or until hospital discharge. Remdesivir is 200 milligrams IV once, then 100 milligrams IV once daily for 4 days or until hospital discharge. I'll go through some kind of tweaking of the dexamethasone dose if it needs to also be used for fetal lung maturity. Looking at kind of the studies, dexamethasone was found to reduce all-cause mortality at day 60 and also ICU mortality, hospital mortality, and the actual duration of the mechanical ventilation, with no differences in things like hyperglycemia and other things that we worry about as being side effects of dexamethasone. Dexamethasone does seem to work better than other steroids. The thought is that dexamethasone, which is more of a pure glucocorticoid agonist, may have less of kind of those other effects, such as sodium retention or worsening ARDS than some of the other meds. If the glucocorticoids are indicated for fetal lung maturity, we recommend 6 milligrams IM every 12 hours for 48 hours for 4 doses, followed by up to a total of 10 days of 6 milligrams dexamethasone PO IV daily. So essentially we kind of front load the dexamethasone to get the fetal lung maturity effect. If glucocorticoids are not indicated for fetal lung maturity, then they get 6 milligrams of dexamethasone daily for up to 10 days, exactly as we would for someone who's not pregnant. Regarding remdesivir, it's an antiviral agent, and it did appear to improve clinical recovery and also reduce day 28 all-cause mortality. It's something that we also use in our pregnant individuals. Monoclonal antibodies are things that can also be used, and we've been using them when indicated in our patients who are pregnant. Then convalescent plasma, there's a little insufficient evidence to recommend for or against the use of convalescent plasma. It is something that we've used in some of our patients because it's known to be safe to use during pregnancy. And so in one of the case reports that we wrote up, we did end up using convalescent plasma in that patient. But overall, in some, there's insufficient evidence on whether or not to use that. In our guidelines, we also use venous thromboembolism prophylaxis. We give a prophylactic dose to all of our patients who are admitted for COVID-19. And if a patient ends up being admitted to the ICU or needing supplemental oxygen, we also give kind of a higher therapeutic dose. We don't routinely give VTE prophylaxis for our patients who are managing outpatient unless they need it for other indications. Briefly wanted to touch on kind of diagnosing severe disease. There's a SOFA score and a Q-SOFA score. The SOFA score kind of takes into things like respiratory parameters, the PaO2 to FiO2 ratio, looks at the MAP, the liver, creatinine requires lab assessments and things like that, and change from the baseline makes the diagnosis of sepsis. What we more commonly use in OB is kind of the Q-SOFA score, which is a little bit more abbreviated. It only looks at low blood pressure, meaning a systolic blood pressure under 100, higher respiratory rate over 22, or altered mentation, and any score that's greater than or equal to 2 near the onset of infection is kind of thought to signal a higher risk of death or prolonged ICU stay. When we're considering ICU admission, there are many things we think about. We have actually a whole algorithm for this, but I'll kind of zoom in on the most relevant part, which is the top part. If we have a hospitalized OB patient, so who's pregnant with COVID-19, we would consider ICU admission if there's any of the following: inability to maintain oxygen saturation over 95% with supplemental oxygen, if they have hypotension despite fluid resuscitation, or if there's any evidence of new end organ dysfunction, such as altered mental status, renal insufficiency, and that kind of thing, we consider the ICU. In terms of timing of intubation, this is something we individualize a little bit more. We consider it if someone is using more than 15 liters per minute of nasal cannula or mask, or if they're requiring more than 40 to 50 liters per minute of high-flow nasal cannula, or if they're requiring more than 60% FiO2 by Venturi mask. Other reasons we consider intubation is if they're unable to protect their airway due to mental status changes. This is just kind of a slide showing when to also consider ECMO or other things. Another thing that's been very useful in ARDS, and that we also have seen to be very useful in the time of COVID for pregnant patients, is prone positioning. Prone positioning kind of increases the availability of, kind of helps to recruit alveoli and increases oxygenation. In the past, I think there may have used to been some hesitancy towards prone positioning for people who are pregnant, with the idea being that if they lay on their gravid abdomen, it might press on it or cause harm. There are special devices for prone positioning for pregnant patients, such as shown in the top right. We actually don't have this where I work. When we do prone positioning, we actually usually just accomplish it by using kind of a pillow for the head, and then we put pillows sort of around the outside of the kind of the lateral sides of the bed, so that the patient's shoulders and hips are elevated and the abdomen has less pressure on it. And so we actually don't have a device like this, but those are nice to have. But with just pillow positioning, we've been able to achieve adequate prone positioning and improvement of patient status. And this is something that you kind of alternate on and off throughout the day. You usually do prone positioning for a certain period of time and then rotate again. Prone positioning can very much increase oxygenation and improve status. ECMO is essentially kind of a lung bypass mechanism. It's mostly only done at very highly specialized centers. Pregnancy itself is not a contraindication to ECMO, but there can be logistical challenges. For example, in my hospital, where a patient can actually get to ECMO is nowhere near anywhere where there are people who are able to achieve a delivery quickly if needed. And so in our experience, we have not had pregnant people who were on ECMO, but I know that at other centers and other institutions, they've been able to realistically accomplish this. Potential indications for ECMO I'm going to put on here. This is typically something that is considered by the intensivist or the critical care specialist, and not by the obstetricians. And so I won't talk through this in too much detail, but briefly, it's something that has to usually be considered pretty early when they haven't been when they've been intubated less than 7 days, and have some pretty severe hypercapnia. So I'll talk briefly about changes to labor and delivery during the pandemic. At our unit, with COVID, we implemented visitor restrictions. Prior to this, we didn't have any particular visitor restrictions. Patients could have as many visitors as they wanted in their labor and delivery room. It could be their spouse, it could be their parents, it could be both of their parents, meaning the baby's grandparents, it could be their friends. One time we had someone who had a couple of dozen people in the delivery room, which was quite a bit. With COVID, we instituted a policy of only one visitor per 24-hour period for our obstetric patients and pregnant patients. We never had a policy where someone could have no visitors, because we believed it was important for the family to be together for this very important event. And also, If the mother wasn't able to provide care for the baby shortly after birth due to having preeclampsia or COVID, a variety of other things, having the other parent there to be able to help attend to care of the newborn was helpful and also helped for bonding. We also allow 2 visitors per 24-hour period for pediatric patients, including newborns. However, visitors to our unit are screened with temperature and symptom check, meaning that when they come into the hospital, they were asked if they had any symptoms such as, cough, runny nose, fevers, headaches, all that stuff. And then a temperature was taken on their forehead before they were able to come into the hospital. In terms of PPE changes, we already use PPE for deliveries and cesarean births. We always wore gowns, masks, shields, and gloves, with the main change being that if someone had COVID, we added a N95 mask, and we also wore gowns and gloves every time we went in and out of the room. We also started doing a COVID-19 test for all patients who were admitted to the hospital at the time of admission. So last, we're going to talk a little bit about COVID-19 vaccine and pregnancy. So the COVID-19 vaccine protects against illness and also severe illness. Pregnant women are at increased risk of developing severe illness, and for that reason, in that logic flow, pregnant women should strongly consider receiving the COVID vaccine. In Peru, Peru started a vaccination campaign for pregnant women in June of 2021. So this is something that is available. Why might a pregnant patient consider COVID vaccination during pregnancy? First of all, it protects the it protects the patient herself from COVID. It protects from COVID illness, and also if the pregnant patient becomes ill, is less likely to be severe and less likely to need ICU stay and death and all that. Also, a COVID vaccine, there can be passage of transplacental antibodies for SARS-CoV-2. It's been shown both from infection with COVID-19 itself and also after vaccination, which is a big step. Essentially, the antibodies that the mom makes to the COVID from the vaccine can cross the placenta and help protect the baby. The World Health Organization recommends the use of COVID-19 vaccine in pregnant women when the benefits of vaccination to the pregnant women outweigh the potential risks, and they encourage pregnant people to discuss this with their provider. The CDC, and I have in quotes here the exact quotes because this is guidance to their patients. They say, yes, if you're pregnant, you can receive the COVID-19 vaccine. You might want to have a conversation with your provider, but it's not required. And if you'd like to, you can enroll in VSafe, which is the CDC's smartphone-based tool to provide check-ins after vaccination. There's also a VSafe pregnancy registry. ACOG and SM2 both strongly recommend that pregnant and lactating people have access to COVID-19 vaccines, and SM2 more recently actually indicated that they recommend that pregnant people get the vaccine. The way these vaccines work, I won't belabor this too much, but essentially the mRNA vaccine, the way they work is they are an injection of mRNA itself, which then teaches the cells how to make copies of the spike protein, and then the body will make antibodies against that, and if your body is exposed to that virus later on, you'll know how to fight it off. Some of the other vaccines are kind of more traditional viral vector vaccines, where it's essentially a harmless version of kind of the virus is injected, and then it teaches the body how to make spike proteins, which the body then makes antibodies against to protect you. Looking at kind of the COVID vaccine and pregnancy registry, in the United States, 136,543 pregnant women had been vaccinated as of July 21st when I made this slide. And of those, we have really good pregnancy outcomes data, and people who've enrolled in the full registry are 5,103. Regarding safety data, despite kind of the Society for Maternal Fetal Medicine's efforts, pregnant and lactating people were excluded from the very early vaccine trials. So we don't have clinical trial data quite yet. However, the The vaccine manufacturers themselves have started a pregnancy study starting in around March or April of this year. And so hopefully at some point we will have data from the RCT demonstrating safety of this vaccine in pregnant individuals. Then more recently, over 35,000 participants in the CDC's VSafe program have outcomes available. There were 827 completed pregnancies in the VSafe registry. And of those, the adverse outcomes were similar to the normal ranges, looking at spontaneous abortion, stillbirth, preterm birth, small for gestational age, congenital anomalies, and neonatal death. And I'll show you a table in a slide or two. So if patients ask, was this very specifically studied in pregnant people? No, but these studies are ongoing or planned. And we also have data from kind of these observational registries. Here's a New England Journal of Medicine publication looking at the rate of pregnancy loss and neonatal outcomes in published studies that have been published and also according to the VSafe Pregnancy Registry. Looking at the outcome of spontaneous abortion, the published incidence in the literature is 10 to 26%, and in the VSafe Pregnancy Registry it was 12.6%. Rate of stillbirth, published incidence is less than 1%, and in the VSafe Pregnancy Registry was 0.1%. Rate of preterm birth in the general population is 8 to 15%, depending on where the study is done in the population. In the VSafe Pregnancy Registry, it was 9.4%. And remember, this compares to 12.8% among pregnant people with COVID. Small for gestational age, the overall rate is 3.5%, and in the VSafe Pregnancy Registry is 3.2%. Congenital anomalies, 3% in the general population, and is 2.2% in the VSafe Pregnancy Registry. Neonatal death is a rate of less than 1%, and the VSafe Pregnancy Registry so far is 0 of 724. So how do we counsel our patients? We actually have a handout that we have, and it's shown here. I'd be happy to send a copy of this along to you as well. And what we do is we kind of talk through this with the patient. We know when they ask. And so they say, I'm pregnant, should I get the vaccine? Options are to get a vaccine or to wait for more information. We give them that option. We go through the risks of not getting a COVID vaccine. We go through the risks of, getting ill with COVID during pregnancy or having severe outcomes. We also talk through the risks of the vaccine itself, mostly fatigue, headache, muscle pain, sometimes transiently feeling a little under the weather for a few days. We also talk about what experts recommend, and then some information about breastfeeding. So at whirlwind pace, I got through these learning objectives. I know I had to cover some things a little quickly. So I am very happy to be contacted with questions or clarifications on anything, or to supply any of the supporting material. If you'd like any of the policy statements or our patient handouts, you're welcome to translate them as appropriate for distribution in your clinic if you would like to. And I'd be happy to take any questions offline. Thank you again for the opportunity to present today at this conference. It's a real honor, and I wish you well and stay healthy.
Muchas gracias, doctora Anthony, por su extraordinaria presentación. Ha sido muy útil, especialmente en esta época de pandemia en la cual nos encontramos. Y en aras del tiempo, vamos a pasar de frente al siguiente bloque. No va a haber, por lo tanto, el receso programado. Así que nos pasamos un flyer de uno de nuestros auspiciadores e inmediatamente el doctor Sandoval se conecta con nosotros para dar inicio al siguiente bloque. Muchísimas gracias.